So following this presentation, we are going to go into the breakout rooms and we're going to discuss how the interprofessional outlooks on the topics covered within this presentation. So first, we're just going to give a baseline of what is aphasia and what it is not. So aphasia is an acquired neurologic disorder, and this can occur from stroke, traumatic brain injury, or a tumor in the brain, and this affects language in different modalities. Aphasia does not involve a loss of sensation or intellect. So that means memory disorders. Aphasia does not cause memory disorders, confusion, or dementia. That doesn't mean that it can't be comorbid with those things, but aphasia itself does not involve intellectual decline. And when we're talking about different modalities, we're talking about understanding spoken language, speaking, writing, and reading. So here we have a picture, and this is just to give us an idea of if we were a person with aphasia trying to communicate, what might that look like? So if we were trying to say, I want an apple, there are different ways that this can present for people with aphasia. So here are just some examples of manifestations that can occur. So there's different types of aphasia: Broca's aphasia, Wernicke's aphasia, transcortical motor aphasia, global aphasia, primary progressive aphasia, and then we also have conduction aphasia. So these here, I want you all to know, this isn't exactly what someone with Broca's aphasia would look like. Everyone with Broca's aphasia, everyone is going to look very different, and it has to do with their lesion, what happened to them, and also the language that they had prior. So here we have a slide that just again stresses the importance of this, that your client with aphasia is only one person with aphasia, and individualizing therapy is crucial for the aphasia survivor. There are different types, severity levels, and comorbidities that make aphasia look different.
I wanted to dive into stroke etiology. First thing we want to talk about is defining a stroke. What is a stroke? So a stroke, or a cerebrovascular accident, or CVA, is an interruption or reduction of blood supply to the brain. As we know, the blood has an extensive and complex vascular system, and it's a network of blood supply that really is important for proper brain function. When that blood supply gets interrupted, the brain is at risk for many issues, including different types of strokes. And there are two different types of stroke. There are ischemic strokes and hemorrhagic strokes. So an ischemic stroke is a blood clot that blocks the flow of blood to an area in the brain. And as you can see on the left of your screen, there's a little illustration of what an ischemic stroke would look like. So the blood vessel gets blocked, and it cuts off all the circulation to that part of the brain. With a hemorrhagic stroke, it's a little different. So in a hemorrhagic stroke, it is bleeding that occurs due to a ruptured artery that damages the brain tissue. If you look to the right side of the illustration, you can see that big red spot all the way on the right. That would be an area that had a ruptured artery, and the blood is bleeding out outside of the brain, which can cause damage to the tissue. And next, we just want to talk about some risk factors for stroke. Some of them I'm sure you've heard of. There are lifestyle risk factors such as physical inactivity, being overweight or obese, heavy binge drinking, and use of illicit drugs. There are also some medical risk factors: high blood pressure, cigarette smoking / secondhand smoke exposure, high cholesterol, diabetes, having a history of cardiovascular disease, having a family history of stroke, and unfortunately, a brand new medical risk factor is previous COVID-19 infection. That's something to just keep in mind, as it's a relatively unfortunately, new medical risk factor. And other factors can include age. Those that are 55 and older have a higher risk of stroke. Sex, men have a higher risk of stroke than women. Race, African Americans have a higher risk of stroke than other races. And hormones, the use of birth control pills and hormone therapies that include estrogen increase the risk of having a stroke.
Hi, so I'll talk about the signs and symptoms of aphasia. So the common signs and symptoms of aphasia will depend on the lesion and the severity, as this affects communication in different ways. So in terms of expressive limitations, this may include word-finding difficulties and the use of single words or phrases, also known as stereotypes. And people with aphasia may also have trouble eliciting grammatical speech. And commonly, some people with aphasia may also make errors in producing words, and this is called a paraphasia. So two examples I'll give are a neologism, which is a quote-unquote new word, or a phonemic paraphasia, but these are just two of them. A phonemic paraphasia is a substitution of a sound in a word, and there are a list of other paraphasias as well, but these are just two examples. In terms of receptive language, some people with aphasia may have trouble with comprehension of speech, and this could be in terms of complex sentence structures, and also people have fast speech. It might be difficult to comprehend. So some more terminology, agraphia and alexia. So agraphia is an impairment in written expression. So a person with aphasia may have trouble writing, and this could potentially help us learn about the person's language. Also, a person may acquire alexia, which is an impairment in reading comprehension. So this impairs their impairs their reading, and could potentially impair their phoneme-grapheme coordination, but this depends on the lesion. And then here's just a list of other medical conditions that may occur alongside of an aphasia diagnosis. So we have the single-sided hemiparesis, which is typically on the right side if you have a left side lesion. Limb pain can be associated with this. And then apraxia of speech, which is a motor movement disorder that affects the speech sounds. And then dysarthria is a weakness of the muscles that involve the speech mechanisms. Dysphagia is impairment in swallowing. And then acquired alexia, which we just talked about. And then unfortunately, sometimes people with aphasia may be diagnosed with depression.
So these comorbidities can impact other areas of therapy. For example, dysphagia can impact weight gain and methods of feeding, which can also lead to social isolation due to anxiety and the difficulty around feeding. Alexia can make it hard to send home worksheets or informational sheets for clients to use when they're at home because of the difficulties with reading. Limb hemiparesis or pain can make PT exercises more challenging, and they may need more time for rest and more time to complete the exercises. They also often have to relearn to write with their non-dominant hand. Apraxia of speech and dysarthria can also make it difficult for someone to express their wants and needs or what they need out of therapy. And then depression can cause people to have less desire or drive to work on skills in therapy.
So when it comes to supporting conversation in people who have aphasia, one of the key things is to allow them to maintain their social dignity. So we do that by focusing on person-centered communication, which relies on empathy and empowerment. I'm also going to talk a little bit about some environmental, physical, and emotional considerations when you're having a conversation with a person with aphasia. And then also a little bit of input from people with aphasia when it comes to interacting with healthcare professionals. This is a quote about empathetic communication with adults with aphasia that really sums up the key points. It's a two-way process where both people are really in tune with each other and really trying to understand each other. And this is important because communication with someone with aphasia is often time consuming and can be frustrating for both people. So as professionals working with people with aphasia, we need to make it really clear to them that we're willing to take the time to understand what they have to say. So what this looks like is creating ground rules for the interaction. We want to make it very clear that the goal of the interaction is mutual understanding. We don't really care how they get that across to us, but we want to know what they have to say. We also want to show active listening when someone with aphasia is struggling. So that means like you don't want to turn away and start taking notes or something, even though it can be very uncomfortable in that moment. And we also want to speak very clearly when we're asking questions. So rate of speech, not like super slow, but clear. And also we want to ask one question each time we ask a question. A lot of times, I know I have the tendency to do this as well. You'll ask 2 or 3 questions at once. And for someone with aphasia, that can be very confusing because of the effects it can have on receptive language. And when it comes to empowerment, it's important to remember that aphasia does not impact cognitive function. So we're dealing with people, with adults, who want to be included in the decision-making process when it comes to their healthcare. So that means that we need to allow for multimodal communication, which includes things, but is certainly not limited to gesture, visuals, so like pictures that they could point to, for example, writing, I blink for yes and no questions, things like that. Next slide, please. When it comes to environmental, physical, and emotional considerations, you want to have low to no background noise and good lighting, minimal distractions, comfortable place to sit. Often people with aphasia are who have hemiparesis are in wheelchairs. So in that case, you would not need to worry about a comfortable place to sit. But if they are not, then that would be something to consider. And we also want to consider patients' fatigue, pain, and emotional distress, because these factors can increase the severity of their aphasia, which can in turn be upsetting and sort of lead into like a cycle. And finally, this is, I'm not going to read everything on this slide, but this is input from people with aphasia when it comes to their interactions and relationships with their healthcare providers. And a key point of it is that they really want their healthcare providers to listen and understand what they have to say. I've included a link to the whole document on this slide because it's a very interesting document, and the information comes directly from people with aphasia.
Okay, so the impacts of aphasia on an individual's identity. Our identities are not stagnant, and they're constantly being shaped by our growing and changing beliefs, relationships, knowledge, and life experiences. So following a stroke or TBI, persons with aphasia or brain injury are often faced with an abrupt shift in identity, with their sense of self disrupted at the center, and other senses of identity, such as their occupational identity, their relationship or familial identity, and their social identity, are all often uprooted overnight. So when speaking of occupational identity, this refers to survivors who were actively employed at the time of their stroke, whose occupation made up a large part of their day-to-day life and their sense of self. So with the onset of moderate to severe aphasia, these individuals are often forced to retire from their professions, creating a sense of displacement, and in turn, they must face a large difficulty with acceptance that they can no longer participate in their jobs in the way that they're used to. So for this reason, it's important to encourage persons with aphasia to find alternative ways to contribute to society, whether it be volunteering, involvement in hobbies with others, or as active members of aphasia support groups to allow for them to reclaim an occupational identity and embrace a sense of self and meaning in daily activities. In terms of relationships and family roles, it is often the case that there are changes in the person with aphasia's family and relationship dynamic. So pre-stroke, the person with aphasia may have held a concrete role in their relationship with a partner or their family. And then post-stroke, the person with aphasia must first accept the new dynamic and then find their new role by shaping their identity, holding on to pieces of their before-stroke identity, and then transforming into the new. And then finally, the person with aphasia's social identity can also be heavily impacted. Individuals may go from being extremely outgoing, social, and talkative before their stroke, and then withdrawing from social events and avoiding situations where they have to introduce themselves or converse with acquaintances. The person with aphasia's social identity and desire to be social can often become much more reserved as they actively attempt to decrease the risk of difficulty and uncomfortability while participating in social environments and situations.
So we know that language loss, such as aphasia, affect identity. We use language to construct our stories of self and to keep a particular narrative going. And the narratives that we create are fragile and can be easily fractured. So what are the challenges that individuals with aphasia face when negotiating their self-identity? Well, there was a recent study which investigated identity in people with aphasia, and the study adopted the concept of identity dilemmas, according to which any claim of identity faces 3 dilemmas. The first dilemma refers to the construction of self-identity in terms of constancy and change. So this would be navigating the dilemma of being or not being the same as before. The second dilemma refers to sameness and different. So this relates to navigating if you're the same as others or not. And finally, the last dilemma, management of agency, is about being seen as a capable agent or not. So based on interviews with people with aphasia, the study concluded that all of these dilemmas are highly relevant to individuals with aphasia. That is, here in this quote, people with aphasia may be both the same as pre-onset and changed. They may be both the same and different in relation to other groups. For instance, manifested as both quote unquote normal and disabled, and they may display both dependency and agency. So we know that people with aphasia navigate the dilemmas through a constant negotiation about what to include in their stories of self. And sometimes their stories of self may be contradictory, but that is just part of the process of identity construction.
Alrighty, so we're now going to discuss the psychosocial impacts that may affect individuals with aphasia as well as their families or care partners. An event such as a stroke that may result in an aphasia diagnosis is a sudden change that is impossible for anyone to prepare for. As we know, aphasia affects communication, and people with aphasia may then have difficulty accessing services that they need, specifically regarding mental health, such as counseling or treatment programs, or even attending local support groups where they can meet other stroke survivors. When thinking about the individual, there are many psychosocial impacts to consider. Research suggests that these factors include poor occupational outcomes, such as maintaining jobs or looking for work, as well as changes in relationships or feeling socially isolated from family, friends, or coworkers. There's also a higher incidence of depression reported in stroke survivors that do have aphasia rather than stroke survivors living without aphasia. When thinking about family and care partners, we also consider these psychosocial impacts, including an increased likelihood of developing depression, and increased stress relating to many different factors, including the overall change in lifestyle relating to how they communicate with their loved ones. The dynamic of the relationship may have changed. They may now be their loved one's primary care partner. Their hobbies and interests may have to be put on hold as they're spending more time caring for their loved one. Finances are another big factor to consider. Medical bills, treatment, this can become burdensome and stressful. And lastly, in regard to severity, these factors are especially influenced when thinking of individuals with a severe aphasia diagnosis.
So this slide serves as a sort of summary of a lot, if not all, of what we discussed tonight, which is really figuring out how to work with and set healthcare goals with the individual with aphasia. So here are a few things that we can all keep in mind when setting healthcare goals, regardless of how the person with aphasia presents, because like we said, one person with aphasia is just one person with aphasia, even if they have the same categorization or classification of aphasia, and regardless of our profession, since this is an interprofessional event. So first, as always, the goal should be client-centered. So regardless of how much difficulty an individual has with aphasia in regards to receptive communication and expressive communication, it's still really important that we include that individual in setting their goals and making sure that they understand their goals. We want to, of course, include the family and care partners as well, but we don't want to direct all communication to the family members, although that might be faster, easier to get that simple response. It can very much feel isolating to the person with aphasia and make them feel like they're not included in their own care and that they're not really part of their own care team. So we want to include the family members and care partners, but also do the best that we can to direct communication and engage and include the individual with aphasia themselves. Actively including the individual with aphasia and their family members helps make for a more conducive goals and care for the entire family, and also a more motivating environment for the person with aphasia. Second, it's important to remember that what might be the primary concern for one profession may be viewed more so as a comorbidity for another. So as a future speech language pathologist, my primary concern and my focus is the language and the communication components. However, for someone who's in physical therapy, your goal might be the hemiplegia. So keeping that in mind and thinking that what one profession is focused on is different than another profession, but regardless, at the end of the day, the person with aphasia, their reality is everything. So it's more than what you're working with, it's more than what I'm working with and focus on, but they're dealing with the hemiplegia in addition to the communication and anything else that's going on as a result of the stroke or aphasia. And then lastly, a lot of this has already been covered in terms of supporting conversation with the individual with aphasia, but some methods for making sure that the individual truly understands the goal when you're discussing it and when you're setting it as well include repetition, rephrasing, gestural communication, simplification of language, and maybe using more than one communication modality. So if we've decided collaboratively as a team that it's the arm that we want to focus on, at the end, after we've discussed it together, we might want to repeat it again and say, okay, so our primary focus is the arm, right? So using the gestural communication, using simple language, and then perhaps the client responds no, and it could mean no, they don't understand. No could mean yes at times if we're having trouble with expressive communication. So just making sure that you're repeating and rephrasing what they're saying, and if it doesn't seem like the individual may mean yes or no, or you're not sure what they mean, giving them the opportunity to express again what they mean. So that is the end. If anyone has any questions, I know we'll be going into breakout rooms shortly as well, but you're welcome to ask some questions now as well.
So we will be going into our breakout rooms shortly. And the speech language pathology students are going to be facilitators of the discussion that you're going to be having, talking about the discussion questions that we came up with and sent out to you ahead of time. I'll put them back up on the screen here in a moment so that you can look at them one more time. So we'll be in our breakout rooms until about 8 o'clock, and we would love to have lots of discussion, everybody in the group sharing, and there are 2 speech language pathology students for the most part in most of the breakout rooms. And we're going to have, one of them be a facilitator, one of them will be sort of taking notes. We might have some opportunity to discuss, kind of hit the highlights of some of the discussion groups at the end of the evening. So I think it'll be really interesting to hear what you learn about in these breakout rooms from each other. And then Dr. Meyerson and Steve Zuckerman are going to join us at 8 p.m. So we'll come back. You'll get a message saying that we're going to close the breakout room, and then we'll come back and we'll listen to that presentation, which I think you're going to find really, really helpful. And then we'll have a little bit of time to reflect and debrief afterwards, and then wrap up the night with a survey, having you reflect again about what you learned in tonight's event. So it's going to be a really good evening, I think. Just a reminder, as we said, these are some of the questions that you're going to be looking over as you're in your breakout rooms, talking about all these different things. And we'd love to have people share from their various professions' perspectives on these questions.
And now it's my great pleasure to introduce Dr. Deborah Meyerson and her husband, Steve Zuckerman. Dr. Meyerson studied and taught about diversity, gender, identity, and organizational change at Stanford University. That career and life path were derailed 10 years ago by a stroke that initially left her hemiplegic and unable to speak. That experience, however, turned out to be the beginning of a life-altering journey into self-awareness for Dr. Meyerson, her family, and thankfully for the many other stroke survivors and their care partners who've come to know her work on identity and life purpose after stroke. Her powerful book, Identity Theft, examines the rebuilding of a life post-stroke and is co-authored with her son, Danny Zuckerman, with help from other family members, including her husband, Steve. If you haven't already read this book, I urge you to pick up a copy after the talk. It will be the one book that you'll want to recommend to stroke survivors and their families on your caseload as they begin their own journeys of self-discovery. In doing so, you'll also be contributing to the nonprofit Stroke Onward that the Meyerson-Zuckerman family has founded to help others navigate their emotional journey to rebuilding their identities and rewarding lives post-stroke. So please join me in a warm welcome to Dr. Deborah Meyerson and Steve Zuckerman.
Thank you.
Can we get a copy of that?
Yeah.
That was really good.
Yeah. Thank you. I'll read one. Thank you.
Let me share screen here. Give me just a sec. I want to make sure I get the right one. Can you all see that? Sorry, I just have to rearrange to get your pictures back up to the top. Okay, Deb, it's all you.
Hi, my name is Deborah Meyerson. In 2009, I began lectures at Stanford like this: confident, strong, and casual. I encourage students to explore topics like gender, race, diversity, and identity. My name is Deborah Meyerson. In 2010, these words came out weak and difficult to understand. But these words were a huge achievement. My stroke robbed me of all speech. My name is Deborah Meyerson. Singing still helps me unlock my words. Who is Deborah Meyerson now? I am alive. For this, I'm grateful and lucky. Many things have changed. I live with disabilities. My right hand doesn't work. I walk with a limp. My speech is really difficult. But some things haven't changed. I cherish the same values, love the same family, work with the same determination. Losing my old life is the hardest part of my stroke. Rebuilding my identity as the stroke survivor with disabilities is the hardest part of my recovery. My stroke took so much of me: independence, career, my control, and so much more. But for me, I was the same person. So I had to get my capabilities back. For 3 years, I worked my ass off. The hardest job I ever had. With all this work, I still didn't regain all my capabilities. I couldn't be a Stanford professor anymore. My aphasia, my speech didn't let me do this job. Losing tenure was a huge blow. What do I do now? Who am I now? 3 years after my stroke, my identity crisis began. I struggled, really struggled. I wanted a book I wrote in 2001, Tempered Radicals. Identity was the big part of this story. I realized my understanding of identity could help me. I decided to write a book. This was academics do to prove I could, but I became my learning journey. It took me 5 years. I learned to accept lots of help. None of us told the emotional journey, rebuilding the identities was so important to recovery. This book is not just my story. With help, I interviewed more than 55 people, diverse ages, backgrounds, stroke types, and experience of life and stroke. Many healthy friends tell me the book helped them. They struggled with the concept of self losing the loved one, health issues, growing older, and navigating other life changes.
So I'm going to jump in and share a little bit more about the book, starting with the whole notion of, well, how do you write a book like this with aphasia? And Deb mentioned that after her stroke, she still works with the same determination, and that is true. So when she decided she was going to prove to the world she shouldn't have lost her job at Stanford and she was still an academic, she sat down to write a book. That's what you do. Pretty quickly, she realized that with severe aphasia, she was going to need some help. She kind of looked for the nearest, cheapest source of additional labor she could find, and that was me. And we probably spent 3 or 4 months kind of designing, outlining, conceptualizing the book, and realized at the time I still had a full-time job and we better get some additional help. We were lucky that a woman named Sally Collings crossed our path. She lived nearby. She was an author, an editor, ghostwriter, and specialized in telling family stories. And so we ended up being able to bring her on board to really help with a lot of the heavy lifting with Deb, designing interviews, doing interviews, coding interviews, and really helping to draft the book. After about a year and a half working with Sally, it was probably 3 years into the project, we were all super excited. Deb and I and our oldest son, Danny, were about to be on vacation for a couple weeks, and Sally was about to deliver the first full draft of the book. And we thought, great, a little bit of editing and off to the publisher. And we all read the book, and it had some great stuff in it, but it didn't deliver the message that Deb wanted to deliver. And by that point, she really believed this book's value would be in helping other people, and it didn't do that as well as she would like. And fortunately, at the time, our son Danny was between jobs. He offered to step in and kind of be Deb's primary writing partner in getting the book from the structure it had in the first draft to what you all, for those of you who have read it or choose to read it, see in the book today. And as was mentioned in the intro, Danny's the named co-author, and just did amazing work to help get it over the finish line. Deb talked about the book not being her story, and I'm not going to take a lot of time on this slide, but when you look at the 25 survivors that we interviewed, there is such incredible diversity in them as people, in their strokes, in their stories. And if we had more time, I'd tell a few of the stories because they're just so incredibly interesting and inspiring. But suffice it to say that they are all incredibly different people. But there were some things that were very similar across all the people we interviewed. First, they all worked incredibly hard to regain as much as they could by way of capabilities, and they did so for years, often decades. Deb's 11 years in and still doing therapy. And I think it's really important to us to tell the world that any trope that the recovery ends after a year or 18 months is just simply not true. And then the second thing, and Deb alluded to this as well, is that none of the people we interviewed felt they had gotten any real help or even noticed that they needed to think about an emotional journey in recovery. People were told, if you're depressed, try to see someone. But the reality is, this is such a major change for everyone. Everyone is going through a difficult emotional time, and none of the people we talked to were offered help for that.
Steve and Deborah, did you mean to stop sharing your screen? Because we're not seeing the slides now.
No.
It says
I am. I'm seeing the slides. You're on the one diverse, and none were offered significant help with their emotional journeys. So I'm still seeing the slides.
Oh my.
Okay. Me.
Whoops.
Carry on.
Sorry, Jackie. We'll send you a copy.
Yeah. Sorry to interrupt.
No, not a problem. So that, that experience of this diversity but similarity is a lot of what really informed the book and informs a lot of our work today. if we were in one room, I'd ask everybody to hold up their hands if they took Psych 101 and was exposed to Maslow's hierarchy of needs. But this really was kind of a pivotal realization on Deb's part and on all of our parts that, Deb was a professor. She was kind of up there in the top part of the pyramid working on self-fulfillment and meaning and purpose. And she just got knocked right down to the bottom of the pyramid where she needed help for her basic needs. She needed help to survive. She needed help to eat. But after 5 or 6 months and a stable medical condition and a certain amount of recovery, she realized there was no reason she couldn't start climbing back up that pyramid, that she couldn't start to build fulfillment into her life, albeit with new constraints. And she didn't put the Maslow's pyramid to it until much later, but that notion was really powerful in terms of Deb's journey to recovery. One other thing I'll talk about is not about the book itself, but about the writing journey. And that Deb mentioned this, when she first started writing the book, it was to prove she could. She was really hanging on to her old identity as a professor, and that's what professors do, as she said. But very quickly, it became the critical journey to her emotional recovery. And the book really became a much more powerful motivator for Deb when she realized she wasn't doing it to prove something, but she was doing it because it would be helpful. We sometimes say the book writing process was the least expensive therapy we ever could have gotten for her and for us. And even then, there were times when she was ready to throw in the towel. I often say that it's an incredibly brave thing when your single most frustrating disability is aphasia, that you should choose a project that puts you in the face of that every morning when you wake up and think, what am I going to do today? Because you're doing something that's just so hard with aphasia. And Deb almost threw in the towel a couple times, but it was really the last part of this journey and the realization that the book could help others that got her over the hump. And I think that really speaks to the power of meaning and purpose in people's lives, and why we focus on that so much in our work. So her writing journey really reflected her own personal journey in recovery. So I'm going to stop there. Deb talked about how understanding identity was a critical part of her recovery, and she had to give up her faculty position, but that doesn't mean she doesn't like to teach.
Yeah.
So I'm going to pass the mic back to Professor Deb.
Yeah. Before I talk about identities, I want to share the process for preparing for the talk like this. I have so much to share. It's really difficult. For me, the hardest part about the aphasia is struggling to say what want to say life and work. To prepare, we write the content. Steve helps. I practice for hours. Even then, I can't say all that I want to say. Steve shares more some complicated materials. I'm so glad he can, but I met him a lot when we worked together. I know it's not mad at him, but mad at my situation. This is life now, but I won't let my aphasia seal my voice. So here I go. let's talk about identities. We all have multiple identities. I had to remember I am more than the job at Stanford. I'm a mother, wife, daughter, and friend. I love biking, hiking, skiing, walking, sailing. Cooking, no. I had to think about how all the things that makes me me. Identities change. We are changing all the time. Right before the stroke, I was not this person. I was 5 years before or 10 years before. My stroke changed me faster, but I am changing out anyway. Identity is construct. We are who we are and conscious of relationships. My relationships, my friends, family, and colleagues were key in rebuilding my life. Most important, identity is the choice. Instead of asking, who am I now? Ask, who do I want to be now? Your sense of self, your identity is profoundly affected with this situation. Your race, gender, nursery, and more.
Take it back?
Yeah.
So it turns out that kind of writing the book for 5 years and getting it on the shelves wasn't the end of the process. It really was the beginning of the process, because we realized what we had learned. One, we needed to deepen that, and two, we needed to share it. And that's what led us to create Stroke Onward. And if this works, y'all should see and hear a little short video to just give you an introduction of Stroke Onward and what we're doing.
In 2010, Deborah Meyerson was a professor at Stanford University, working on issues like gender, diversity, and identity.
I'm really happy to be here. I spoke at a NET-INTAF conference.
She was also a happily married mother of 3, healthy, fit, and athletic. Then, a severe stroke nearly killed her, leaving her paralyzed on the right side and with no speech at all. For 3 years, Deborah pursued every avenue for therapy possible. Despite great progress, she could not return to her job as a professor, mostly because of her ongoing speech challenges. That led Deborah to ask, who am I now? Drawing on her background studying identity, Deborah and her family began to explore their identities, and the emotional journey they now know was critical to rebuilding a rewarding life in the face of disabilities. That was an integral part of the 5-year process to write Identity Theft, Rediscovering Ourselves After Stroke. More than a book about Deborah, Identity Theft is built on academic research and interviews with more than 50 survivors, family care partners, and professional caregivers. While writing the book, Deborah and her husband, Steve Zuckerman, heard time and again that survivors and their families get little help navigating their emotional journeys. So they have created a nonprofit called Stroke Onward to bring awareness, develop resources, and ultimately change caregiving systems to embrace the emotional journey as an integral part of the recovery process. Deb and Steve are adapting their life personally and professionally to continue enjoying what they love, and by building Stroke Onward, trying to make the stroke recovery system better for the millions who will, unfortunately, be forced onto that path in the years to come. Please join us to learn, collaborate, and create a better healthcare system together.
How can I go?
Yeah.
See, she's still just as determined. She also likes to control me, so it all works well. So won't talk a lot about Stroke Onward. You can read the mission of our organization, or at least the way we've articulated it. And it really is about trying to get the emotional journey to be as focused on in recovery as rehabilitation. And kind of our view of how we can make a difference. And if you start at the bottom of the pyramid, we want to do things that help people. We want to create resources that help people. And we hope we can help thousands of people that way. But by partnering and collaborating with other organizations, like many of those we hope that are involved in this session, we can leverage any work we do to reach many, many, many more people. So a big part of our strategy is to collaborate. And finally, we hope that we can change the system, that both directly and through the accumulation of the work we do, that people who experience a stroke or the family members and enter the stroke care system will encounter a different system 10 years from now than they do today, and than we did 10 years ago. And I'll talk a little bit more about that in a sec. Kind of our strategy is really threefold. One is to raise an awareness. We're speaking and writing about this issue as much as we can. Events like this help, certainly. Probably our most notable writing is that we've got an every other month column with the American Stroke Association to write about this issue in their newsletter and on their website. And then creating and sharing resources, a project that Jody led to create book discussion guides to make it easier for groups of survivors or care partners or professionals like yourself to read the book and discuss it, is one of the things that's now available on our website, free to download, and that we hope will help share the message and contribute value. And then when it comes to changing the healthcare system, I think we really have great hope in you all. You're the next generation of care providers that stroke survivors are going to meet and are going to depend on. And so one of our most active projects is looking at ways through things like this and beyond that we can try to get this material, these concepts, into the educational curriculum for the next generation of care partners across all the disciplines. And that's why we are so excited to be working with you all in this interdisciplinary, because we think that it really does take all of the different care elements to focus on the whole person in recovery, which is what our efforts are all about. If you're interested, we just published on our website, and I think our web address is or will be in the chat. We just posted our first ever impact report. And I think, on the one hand, we're very pleased that we've been able to accomplish a lot in our first 2+ years. But what's even more striking to us is how much more needs to be done. And that's what motivates us and drives us forward. And the last thing I'll share is just a little bit of a glimpse in the future that we've only started talking about in the last few days, and we only put in this presentation because you all are in Western Massachusetts.
Yeah.
But we are going to do a stroke awareness bike ride across the country next summer.
Yeah.
We're riding our funky tandem rig, supported, and it's a little too small to see, but our current route that we hope will stick is going to take us right through Western Massachusetts. So for all of those who will still be there in give or take mid to late August next summer, we hope we'll be able to organize something to be able to bring awareness to these critical issues out there in Western Massachusetts. So with that, I'm going to pass it back to Deb to take us home. Except I got to get the slide.
My journey is full of challenges. I am building a different kind of career. I have new limits, but I am again a partner and the athlete. Yeah.
Sorry.
The active mother, partner, and athlete. I am still rebuilding my identity and rebuilding my life. So who am I now? I'm a stroke survivor. I am frustrated really more than I used to be, but I'm lucky to be alive. I have great support. I am building a new life. And I have purpose and meaning again. I am committed to helping other survivors and their care partners. To be clear, we are not figured it out. We are still on the journey, and we will be from life. Thank you.
And I just want to add to Deb's thanks to thank everybody who was involved in organizing tonight's event. We know there were tons of people who made it happen. Special thanks to you, Lisa and Jackie, who we know worked really closely with Jody to involve us in this event, which we so appreciate. And Jody, thank you for making it happen from our end. We really get so inspired when we have the opportunity to meet with and talk with students like you all. And so thank you for, after a long day, putting up with yet another session and for doing the work you're doing and that you will do in the future. So, you know, we hope that maybe there's something in what we talked about doing that tickles your fancy. If anyone wants to get involved in what we're doing, as I said, collaboration is key to the way we want to do what we do. So please do reach out and let us know individually or institutionally if there are ways we can work together.
I was going to ask the students to join me in thanking you, Deborah and Steve, but I don't know if you've had a chance to see the accolades in the chat, but we will send them to you. But from the bottom of my heart, thank you so much for your generosity and sharing this incredible experience, but especially for opening up this topic, this complex topic on rebuilding identity. It's so important, and the work you guys are doing is just kind of blows me away. And then your cross country trip next year. Wow.
6 months.
Well, one thing was, I don't know if y'all caught it there, but I got sidetracked looking at all your comments in the chat and I stopped doing my job. Deb was like elbowing me saying, would you advance the slides, please? Yeah, no, hopefully, and we'll be in touch, but hopefully we can try to figure out a way to organize something. Assuming it all happens and we're still riding, or even if we're sitting in the car, you know, we're not going to let muscles get in the way of going all the way across the country, but hopefully not. But hopefully we can do something, and hopefully some of you can jump on your bikes and ride for a day or two with us.
Yeah.
That'd be great. Are there any burning questions from the 145 of you that are still there?
I think if you like raise your hand, then your picture pops to the front so we can see you. Oh, this does not look like a bashful group.
You guys already answered my question. I was going to ask if we could join you on your ride when you come through. I think I could probably get you 100 people to go with you at least. That'd be really awesome, actually. So we'll follow it. Do you guys have an Instagram or anything?
So we will. We hope to kind of officially launch the ride in about a month, where we'll have a website and more information about what the route is and how people can join. We put our emails on the final slide. You may not see it, but it's just steve@strokeonward.org. So if you're particularly interested in learning more about, or maybe helping to organize some local riding, shoot me an email, because I'm collecting names, and it is our hope to have multiple ways that people can join for a day, for a week, longer, fully on your own, or we're trying to work with a tour group to actually organize weekly segments that people could sign up to do a trip that goes along with us. So.
And strokes, stroke and brain injury.
Yeah, we're hopeful, not 100% certain yet, but we have a very close family friend whose daughter, who's in her mid-30s, unfortunately suffered a traumatic brain injury. She does not have aphasia, but has some ongoing disabilities, and we think she's going to join us for the whole trip. And so it'll give us the opportunity to talk a bit about TBI as well, and a lot of the dynamics are very similar with stroke.
We lost your video feed too. We missed your faces already.
Let's see.
Just the camera.
Yeah, I think you just have to turn your camera back on.
Oh.
Have to get the cursor to the right. Oh yeah, there it is.
Yeah.
I'll get it.
Yeah.
You got two type A personalities. When two people try to work one touch screen, it doesn't work very well. Touchpad. Are we back?
You're back. I do have a question if none of the students do, but I'd love to hear the students' questions first and foremost, but I don't want to take up space from them.
Yeah, we've both taught in business schools, so we cold call. We could just start calling on people.
I think my question might be pretty relevant for a lot of these young professionals here. One of the things that I think I want to go back to what you were talking about with the adjustment to the stroke, and about, how difficult it is to adjust emotionally, particularly. And I know that a lot of times people wonder about, should I be referring my patient with aphasia to, a counselor, or, that whole question of what's the best thing to do to assist if you see the person that you're working with struggling emotionally to adjust to what's happened to them. Can you talk a little bit about that?
You want me to go?
No, yes.
So, I mean, that is such a great question. And the unfortunate answer is that with most of the people we've worked with, when they say they see that need, they can't find anybody to refer to. And it's one of the gaps that we think we've identified, which is for some reason, most of the therapy, psychology, counseling professions haven't really focused on stroke survivors. And
the aphasia,
in particular, they haven't developed skills to be able to communicate effectively with people with aphasia. And we're actually involved in one project right now at University of Pittsburgh, where a faculty member is running a study where they're training speech therapists on a particular form of therapy called acceptance and commitment theory, so that they can, in effect, because there are no counselors out there already trained in that they can refer to, they're trying to train people who are working with people with aphasia to see if that helps outcomes. And then I think there's another project that Jody's just been hearing about with a partner that we've been working with a little bit, where they're going to try to do some training of therapists as to how to better communicate with people with aphasia. So it's kind of opposite sides of the same coin. And we think that's an area that needs a lot of work and attention, and we're trying to figure out how we might be able to contribute to that. I think the other thing that we talk a lot about is, you know, our experience of the stroke care system draws a very clear line between people who are clinically depressed or have clinically diagnosable anxieties. And that's probably about a third of all stroke survivors. But the reality is everybody else, just because they're not clinically diagnosed, they still need emotional support.
Yeah.
And I think that's another one of the messages that we're hoping to convey. In fact, we've been drafting some materials. We've read a whole bunch of the stroke recovery guides that hospitals point you to when you're discharged, or the American Stroke Association. And they all talk about depression and seeing a psychologist or a psychiatrist, a counselor, but none of them talk about this broader emotional journey. So we're exploring ways we might create material that folks could use in those kinds of guides.
Yeah.
And Emma, we see your hand.
Hi, my name is Emma. I'm a junior nursing student. I was wondering how you felt about like nurses' roles in your care, especially in the hospital. Do you feel like they made a huge like difference in your recovery? And then maybe what's something that could have been better for you?
No, I am 4 weeks on intensive care, and I am the one nurse.
You want me to tell the story? Yeah, no, I mean, I think the story is that Deb literally could not make a sound, and she could not move the right side of her body. And she was in the intensive care unit. And I don't want to offend anyone, but like every once in a while you come across people who just use that syrupy voice that like you're talking to an infant almost. Yeah. And this woman came in and was talking to Deb like that. And I could just see her face starting to boil. And the woman turned around to walk out. Deb starts going, just shaking her left hand at her. And literally, it's the only time in our entire experience that we asked the charge nurse never to send that nurse into our room again. But I think the broader message there, and particularly with people with aphasia, is just assume that the patient is fully conscious, fully cognizant, and wants to be part of their own care.
Yes.
And that's what made a difference. The nurses and doctors and others who talked to me and talked to Deb's mom. We were the two principal support people, and to Deb, so that they were talking to us as a group, as opposed to some who talked to us as if Deb wasn't there.
Yeah.
And I would say in that early phase, I mean, most of our work now is focused on much later in a person's recovery when they're probably not interfacing with nurses as much. But I think you have a lot of power as a nurse to help reinforce that notion of patients' power and patients' agency in their own care. And if they develop that in the hospital, then they can carry that out into the world when they need more agency because nobody else is going to look out for them.
I agree completely.
I appreciate that. Thank you.
Is that on tape that Deb agrees with me?
Yeah.
It doesn't happen often.
Yeah.
I think it's really beneficial to hear that, especially before like working as a nurse. I know that I'm not really comfortable with aphasia, but definitely to keep those things in mind is good. Thank you.
Yeah.
And boy, I'm afraid to try to pronounce your name. Ian?
Hi, it's Owen, actually.
Owen, okay. Figured one of those two letters had to be silent.
It's true. I was wondering, thank you so much for sharing. And I was wondering if occupational therapy played a significant role, or if you could, if both or one of you guys could highlight like how occupational therapy impacted you, if it did, how it did, or else what domain or professional, like a practitioner, impacted you a lot like that. If you could comment on any part of that, that would be.
I still see the occupational therapist once a week.
Yeah, I mean, occupational therapists were huge in Deb's experience. And I have to tell my favorite occupational therapist story is a woman that we worked with for about a year, from 6 months after the stroke to a year and a half after the stroke. And she's remained a friend. And we were talking about this issue of the emotional journey and how to talk to people about it. And she said, Deb, if I had raised the idea that you needed to rebuild your identity and think about a new way to live your life, I would have ended up with a black eye, a bloody nose, a fat lip, or all three.
Yeah.
And she's right, because until 3 years out, until Deb lost tenure, and that was the moment at which she had to acknowledge her life was going to be different forever, she wasn't ready for that conversation. And so I think, for occupational therapists, physical therapists, speech therapists, all of you, as you're working with people, understanding where people are in their journey, and therefore how best to support them is a really important and probably not too talked about soft skill.
Yeah. And the nursing and social work.
Yeah. We sometimes talk about whole person care, and it doesn't matter what your specific discipline is. The more aware you can be about all of a patient's or client's needs, the better you'll be able to bring your particular expertise. Michelle, nurse, we're getting all that. This is so exciting. We're getting questions from every discipline. I love it.
Hi, thank you so much for sharing your story with us. It's been a very insightful evening. My question is kind of piggybacking off of the previous one. In terms of a skill, what would you want if you could only use one skill or one thing that you wish every healthcare provider that you have come across or will come across in the future in working with stroke patients and aphasia patients? What's one skill or one thing you would want them to know or do for you?
That's slow down.
That's a
No, I so down for me to get my thoughts and order.
Yeah, for people with aphasia, that's a huge one. And it was surprising to us how often neurologists, other well-trained in the stroke care system people would ask a question, and when Deb didn't respond within 2 or 3 seconds would move on.
Yeah.
When in fact, her brain was just still processing and forming a way to respond verbally or non-verbally. I think the other one, and this is something that if anybody's interested, particularly those of you involved in the academic side of all these different disciplines, we think that if some form of counseling education were part of the curriculum for every discipline, not that that's going to make you a trained counselor, but that the skills that counseling is all about, if you could bring some of that, we think that would make all practitioners better able to identify with the emotional journey.
Yeah.
So that would be my answer.
Yeah, I agree.
So if it's offered as an elective, take it.
Yeah. Yes. Yeah.
Hi, I'm Tara. I'm a social worker, actually.
Yeah.
And so I'm at Westfield right now in Pioneer Valley. But I just want to say thank you for voicing that, because I always think everyone should have social work curriculum and everyone should have that. And I think in my training, that's why I chose to come tonight, was I wanted to learn about aphasia. I wanted to see how my role can play a part in this. So it's really exciting to hear all of your ideas, and it's inspiring me. And I'm currently working with children who've experienced trauma, but I'm thinking anyone who's had aphasia it's partially, trauma. And so learning how to work through that. So thank you for sharing.
Thank you.
And these interdisciplinary programs, I mean, we were trying to remember, I think the 3 disciplines were speech therapy, nursing, and might have been social work, where they were doing practicums where the speech therapist was teaching the other 2 how to better communicate with people with aphasia. The counseling trained folks were bringing that. And so it was a cross-disciplinary experience that just to us seemed incredibly powerful.
Yeah.
So.
Yeah. Really, I agree.
Twice in one night.
No.
I don't pay for that one later. Should we start calling?
Yeah.
I don't know. Anna Wynn, you just smiled when I said that, so you must have a question.
I didn't, but I kind of do. I always kind of do, right? For those who know me, I talk too much, so I'm trying not to talk too much. But actually, when you were talking about mental health and how there are no counselors who seem to specialize in stroke surviving, or like in stroke survivors, I was thinking about, do you think that it would be good for speech pathologists to work maybe like collaboratively with mental health counselors? Like, I'm just kind of imagining this dual practice when they're both in the room, the speech pathologist kind of guiding the conversation and the mental health counselor doing that part. What do you think of that?
Yes. I agree completely. It's really important.
Great.
Did you make that happen?
Yeah.
Across the country and around the world?
So my husband is a mental health counselor, and that's where my head has been this whole time. But I don't know if I can get him into it. I don't think he wants to work with me.
I was going to say, I'll try to get back in Deb's graces by saying there's nothing better than working with your spouse. It's awesome. All right. Who do we want to call on next, Deb?
Suzanne.
I don't have so much a question as a oh dear, now my head it's gone, but I'm a social worker, and Tara and I are both in a program that's about integrative health and how it impacts the social determinants of health, and how if you can't bring all of our workers, helpers together so that they can cross-discipline, kind of commune on what is needed, then you really can't treat the whole patient. And, you know, to have everybody just siloed with their individual expertises is not ever really the best way to treat a patient. And I think that and hearing you say that, you know, there are no mental health practitioners who specialize in aphasia, it just really made me incredibly sad, and gave me an idea about, oh, well, maybe that's a project that needs to be done. But yeah, that's all that I'll say about that for right now. But it's just, I think that somehow constructing clinics where professionals can meet in tandem so that understanding goes across is going to be a wave of the future, because of what you've experienced. So
yeah, couldn't agree with you more. And I think, you know, we've batted around whether we might be able to find some academics in the counseling disciplines that might be willing to do a study where a group of counselors pair up with, you know, a stroke clinic and, you know, do kind of a study to look at the sort of personal happiness outcomes over a period of time to a group of people who are just being treated by speech therapists and those who get counseling on top of that. And you know, we're not set up to do that research, but we've talked about whether we might be able to find collaborators who could. Mimi.
Hi, just thinking about, you know, like you mentioned, as much as we'd wish we could have a greater background in counseling, even when we do take a class, we don't really become like full-fledged mini counselors. But what sort of counsel did you get that you found effective and helpful from folks who are outside of that maybe direct profession? Like how can we as OTs, SLPs, when we're offering counsel, be effective when working with folks who have had strokes or folks who have aphasia?
You really are. 11 years is a long time. The three periods. One is the hospital, and one is, no, three,
You're talking about like sort of the phases of your recovery?
yeah,
Kind of the clinical, critical care phase, then the
yeah,
hardest job she's ever had, got to get back to who she was. Then I would say there's the sort of the book writing
Yeah.
phase, which really was your emotional journey. And then the current phase, which started in 2019 of kind of, okay, building the new life.
yeah.
I think, could you ask your question again? Because I did have a thought, but that's what happens when you get to be my age. You forget the question that was asked.
No, I probably wasn't entirely clear either. I'm just wondering, given that we're maybe like as a future SLP, I have some background in counseling, but not, as much as I could. What kind of counseling did you get from professionals in maybe the SLP field or other, adjacent fields that that you found helpful? Just what sort of are the characteristics of that kind of counseling that worked? Or
I think what I would say is we didn't get much, and that's why we're here. And that Deb was a social scientist, she was a professor, she studied identity. And so once she decided or realized or accepted that she did have to build a new kind of life, she had a set of tools herself that most survivors don't have.
Yeah.
And we brought that set of tools and thinking and the conversations we had about it out to our care professionals. And we were fortunate that a lot of them really were like, yeah, this is the right stuff. And some of Deb's speech therapists in particular, but also occupational therapists.
Yeah. And the physical therapists too.
Really became quasi counselors, people who, because they were just naturally, they hadn't been trained in counseling, but they were just wonderfully counselorish people. And I think that's kind of what our work is so much about, is that most people aren't going to happen their way into this. And so the system needs to make it part of what it does.
Yeah.
And we wish we had the answer and could snap our fingers and make it happen. We don't, but that's what we see as the journey for us, and as many people as we can rope onto it as we can. But hopefully you all will be those counselor-ish kinds of people who will think to ask the question when you see the opening and see that somebody's ready for it.
Yeah.
And that in and of itself will have huge value.
Yeah.
Thank you.
The book is, the audio book is 2 years out. The audio book is.
Yeah. Deb likes to talk about the audiobook, one, because it's really important, and two, because she fired our first publisher because he wouldn't agree up front to for sure create an audiobook. And she knew that was critical to a lot of our most important audience. So.
Jackie, you have your hand raised. I guess we have time for one more question.
Hello. Hi, my name is Jackie. I'm an SLP student at UMass. And I know you touched upon saying that writing the book was extremely therapeutic for you. Deb, both you as a stroke survivor and for your family as well. And I was just wondering, other than writing the book, what was a really great either therapeutic moment or a therapeutic time in your life that helped you all grow? Just thinking about my future patients, I really enjoyed the book. I've recommended it to all my family members and friends. And I know it's something that I'll recommend moving forward, but just any other therapeutic moments that you can maybe touch upon that we could I could hopefully integrate in the future, or just anything like that to help support our patients in the future, if you don't mind.
Yeah. I really a lot of
Want me to go?
yeah, I don't know.
Yeah, I mean, that's a hard question because it does get at it just sort of gets at the and a bunch of the other questions about integrative medicine and how do you get the counseling profession sufficiently involved, or people like yourselves who aren't going to be counseling professionals to have enough of that skill. And again, Deb is a social scientist and taught organizational change. And I mean, between us, we've probably done, 20 workshops that are some form of introspection. We're not the normal audience for this stuff. How do you build a healthcare system that can serve people who haven't done that, may not have done that much personal work before their trauma with stroke? So I'm going to chalk that up to one of the great questions that hopefully over the next couple of years we begin to find some answers, but it's a tough one.
Yeah, I agree. Yeah, thank you. And what is the
Owen?
Yeah.
Owen put a comment about co-treatment. Yeah.
Oh, from an earlier comment, I was just wondering about since OTs have mental health training, some of those earlier comments were making me think about how if we can develop some of those goals directly into the treatment, or if we should or could develop our mental health training to address some of those counseling needs, maybe with a speech language pathologist. So I was wondering about that aspect. It wasn't really a question. Sorry.
I mean, that's actually what getting a little feedback is is training in mental health standard and required in all OT programs, or is that maybe unique to yours? I haven't heard that before, that there's mental health in the standard OT training.
There is. I can't speak on every program's level of what the requirements are in every program. Ours has a very good focus, I would say, at AIC, but and it's a foundation of our profession, actually, which one of my classmates just pointed out in the chat. And I'm just wondering, that's why I was wondering how we can support, how speech language and OT can support each other when making those progressing those goals, to make sure we're really checking in with our clients, maybe increasing the number of professionals who may be coaching or co-treating towards guided counseling goals with SLP, with speech language pathology in the field or in clinical settings, maybe.
Yeah.
No, that's great, and thanks we're kind of reading the comments as they're coming through, and I think it's a great avenue for exploration. And one of the other issues that you bump up against is, like Deb, very often it's a year or 2 or 3 before somebody's really ready to acknowledge they can't get all their capabilities back. And in our medical and insurance system, very often by then, insurance, if they had it, gets cut off. So they're disconnected from OT, PT. They just don't get it anymore unless they're in the privileged few that can pay for it themselves. So, that timing issue comes into play again, but this is all great.
Yeah.
We learn a ton from your questions, so thank you.
Thank you. Yeah.
it makes me think of my fiance's an OT, and he was in mental health setting, and a lot of the goals that he worked on was purpose and meaning. So looking at, so a lot of you've made these goals for yourself and you've done this therapeutic approach for yourself, but I think doing that in every setting, looking at, you know, what are the logistical things we want to work on, but what are the deeper things that we can work on together in your life? Because it's also looking at the process of trauma as grief and loss and accepting that and moving through that to make meaning again and connection.
Yes.
Absolutely. Just looking at some of the comments. I mean, has there been lobbying on extending insurance coverage? You know, yes, but to no avail. I mean, you know, just the whole healthcare system is so intractable, and the insurance system is the worst part of it. So, I mean, we think that is a place, and we actually see a little more work. We haven't done deep work internationally, but in a lot of other countries that have a more socialized medicine, single payer medical systems, there does tend to be more attention to these whole person issues.
Yeah.
And we think one of the reasons is that people can get treatment, covered treatment longer.
Yeah.
Thank you so much for bringing up my comment so we had the opportunity to ask you guys and explore it with everybody here too.
Well, we expect all of you to figure it out and give us a call and let us know what the answer is.
Yeah, really, yeah.
I want to thank Deborah and Steve again for this really rich and beautiful conversation. And thank you all for showing up. I'm looking forward to hearing about the facilitated discussions. Please don't forget to fill out the post-presentation survey, post-IPE survey before you leave tonight. And we'll be in touch. There's some great ideas that came up tonight.
Yeah, I agree. Thank you.
And we know it's 9:15 for you all, so we're gonna have a glass of wine in your honor.
Yes.
Thanks so much.
Thank you.